Hi, guys.
No, just give, okay.
Yeah, we are there. Danae, can you hear us?
Yeah, I can.
Very nice.
You may start
Perfect.
the
Very
case.
nice. Okay, so thanks for giving space for doing this case. We are just showing the technology. I'm not speaking about the patient. He is indicated for VT ablation ependo, and Vivek will show you the technology, how to get non-separated pericardium access, okay?
So maybe we'll just go to the slides really quickly. We just have 2 slides to show. Hopefully you guys can see them. So this particular technology is called the PRAGUE device. I can't even read that. Can you read that? Okay. Anyway, you see the device there. We're just going to show it to you. The concept is very simple. The idea is you take the device, push it up against the pericardium. Then there's these tines that come out to engage the pericardium. You withdraw to pull the pericardium away from the heart. And then you puncture with a small needle. And then through that, you put a guide wire and then engage. And so if you just go to the next slide, I'll show you really quickly. If you look at this slide, so this is just on the bench, and you see the idea. You're pushing up against the tissue, engage with the tines, and retract. And then you can imagine puncturing. So here's the actual technology itself. This is the, there's an obturator that comes here. There's an obturator that comes here. Hopefully I can see this. This is the access cannula. Once we put it in, we take out the obturator.
Vivek, you're still on the slide. Just let's. Okay, there you go. You can start from the beginning there.
No, we are okay.
Oh, okay. So, oh, I see. Okay. So here, this is the cannula right here. This is the obturator. With the obturator in, we're going to enter. Then we take out the obturator. We put in the device itself, which enters. And you can see right here, this actually is what allows you to advance the tines. It's hard to see. Maybe I'll turn this way.
Now it's perfect. Now it's good.
Maybe you can see the tines, maybe you
Now it's
can't.
better.
They're very small
Yes.
tines anyway. And then once the tines are out, and you can and we retract, we puncture with the needle, and then advance the guide wire. So with that, let's go ahead and get to it. Okay. Is this contrast here?
Yes.
Okay. So let's get to the patient. So we have this in lateral view because the lateral view is very helpful. Where am I? Okay. So you guys see a fluoro, hopefully? Let's have them see the fluoro, please. Let's split the fluoro and the...
Zinco fluoro.
Can they see it? Oh, I think they can see it, right?
No.
Yeah, now they can see it.
The main screen.
It's okay. No, they have it over there, Peter.
Okay, perfect. Okay.
All right, so let's get going. So we're going to advance the cannula. So now here, let's look at fluoro. That's a little low. Okay, there you see the cannula at the bottom of the fluoro screen, I hope. And we're going to advance this in. So the purpose here is to get underneath the sternum. Can you switch these screens?
Marťás, přehodíme rentgeny.
So I'm advancing this till we get just anterior. Okay, so now we went through this anterior pericardium. Okay, yes. That'll be easier.
Okay.
Okay. Can they still see it, hopefully?
They see it.
Okay. All right.
Okay, nice.
Okay, so now I'm anterior to this. And it's, I sort of feel like maybe I'm feeling the pulsations. It's hard to tell, honestly. Take this guy out. Now I'm putting in the access device. And I have a little bit of contrast here. Let's get the cannula, the wire ready. So at this point, I'm going to inject a little bit of contrast.
Perfect.
I feel like I'm up against the tissue. And actually, I'm going to just load the wire up before I do anything else. So the wire is just put inside. So I'm pushed up against the tissue, advance the tines, and pull back. I feel like I got something. Yeah, I think I got something.
Do you want to zoom?
Needle. No, I don't think I got it. Okay, let's do that again. So I pull it back, up against tissue again, this time a little bit harder. There are the tines. Pull back. Needle.
Okay.
No. Try again. And sometimes I go to a slightly different location. There's the tines. Pull back. Needle. No, it still doesn't want to go across. Okay. Pull the needle back. Sometimes if it doesn't work after 2 or 3, then what I typically do is I put the obturator back in, and we try to go to a slightly different location. And we like to do that with the obturator. So here's a slightly different location.
Contrast?
Nah, it's
No?
okay. Well, no, it's a good point. Yeah, let me just have the contrast. We'll do one more contrast injection. Yeah, okay. Okay, now I'm going to load the wire back in.
No, no, no.
Okay. There.
No.
Tines. Pull back. Needle. Still doesn't want to go there. Oh well. C'est la vie. No, that time. It's interesting.
jumped,
It like
jumped.
yeah, it like caught, but then it gave way. You know, there's another
It jumped.
possibility. This patient may have
Adhesions.
adhesions. Yeah. But it really is. I want to go to a different location.
Okay.
You know, we see that sometimes. There's some patients, as we know, we don't think they should have adhesions, but they do. So I'm going to just take a different approach angle here. Go to a completely different location here. It seems like the same, but I actually took a different angle. Let me have the
No.
contrast. Yeah. Try again. Sorry, guys. I thought this was going to be quicker than we. Yeah, no. It's a different location, but we'll see if this is.
You guys show the X-ray instead of yeah.
Wait, they're not seeing the X-ray? You guys should be seeing the X-ray. Oh,
The
there,
main
this one's
X-ray is
somewhere.
on main screen. Now it's good.
Well, it's somewhere. I
there.
don't know where it is.
Uh,
It just may be anterior. Let's see.
doesn't matter. It's okay.
No, I
Yeah,
mean,
no.
like, I don't know if it's
You
actually.
mean pericardium?
Yeah, just maybe outside the pericardium. Let's. LEO is good, I think, Peter.
Okay. Okay.
No, it's just outside. It's just in the mediastinal area. I don't think it's doing anything. Wait, do you see it? Yeah, no, it's not going anywhere. Fluoro? Yeah, it's just not. It's just in the mediastinal area. Okay, let's go back lateral, please. Okay, let's see where we are.
Då David är det.
Okay, let's see here.
Ja, det. Ja.
Good. A little bit more force. Okay, retract, needle, advance the wire. Nah, it's just
Try-
not. I think it's just going up out of. Nah, it's just in the pericardium. It's just in the mediastinal area. It's not actually coming around. Let's go to a different. I think I'm going to have to take a completely lateral approach here. Let's try one more time laterally here. Go.
Should I go?
Yeah, no, it's okay. I'm going to go here. Let's take it a little bit higher. So I'm going to take a little more of a lateral approach here. So this is a completely different angle here. May I have the contrast again, please?
Yes.
Yeah, it's extrapericardial still. Probably close. Okay, let's try again. It's really rigid. It's interesting. I think there are adhesions here. It's very interesting. Huh. Well, let's see. You know, usually when you pull back, there's a fair amount of give that you have with this. And the fact is, there's not much give at all.
Good luck.
Yeah. Well, it may be that we just have adhesions. I may not be able to get in here. There's a lot of oozing from the skin puncture, by the way. That was from the very beginning. What I may try to do is, let me try one more time in a different angle here. If this doesn't work, I think we're maybe out of luck here. You can even see the heart, the catheter moving with the heart. I know I'm anterior to the heart right here. Give me a little more contrast, please. If this doesn't work, I'm going to try with a needle, and then we're going to give up. Because I think there are adhesions. You can see, it's clearly
fantastic contact.
Well, I think I had good contact
Very
before.
good contact.
Yeah, but I had good contact before also.
Yes, I know.
Meanwhile, this wire's getting mangled. Okay, so we have contact. Okay, it's tines, withdraw. I think that came back too far.
Should I try?
Maybe, go LAO. I don't think this is in the right location.
Sort of.
Okay, that's good enough.
Okay.
Yeah, maybe.
So- Like it's,
Okay, let's see, where is it? Show me the lateral part of this thing. Actually, maybe okay.
okay. Can we go AP?
Yeah.
That's perfect.
Okay, this is a little more. Nah, it's not even
It's
there. It's just mediastinum. Can you go back lateral one more time?
Vivek,
Yeah.
this is Tom. Hi. Any comment while you try to figure this
Yeah,
out? Any
yeah.
comment on where you aim typically with the device? You seem to be
Yeah.
aiming more or less at the annulus level. Any thoughts on trying
No.
different
well,
targets?
No. Well,
No, it's
so
not.
when we do this, we always go anterior. So we always use an anterior approach here, because that's how the device is designed. I mean, could it be done inferior? I have no idea. I've never tried inferior, but it's always anterior. The goal is take the obturator cannula assembly, get through this anterior pericardial ligament, which tends to be pretty strong actually. Get through that ligament and then puncture across and move forward. Yeah, I'm telling you, there's adhesions here. So this is really the same location. I've never tried inferior with this device, so that's not something the device is really designed to do.
Liberac, can we go apneic?
No,
It's
I
not
understand that.
happening,
I guess my
Shiv.
question was more in terms
Yeah.
of how high or low on the anterior surface you are, where
Oh,
you might
I
be
see.
more or less perpendicular.
Yeah, we try not to do perpendicular. I mean, I don't see any reason why you couldn't. I mean, I could do that. I can come back a little bit more this way. But I don't think that's... Yeah, I don't think this is the issue.
Contrast, no contrast.
No, this is... It's just not... no, I don't think... I don't think he's... he actually has...
Okay.
I think he's got...
So
we can
let's-
try a...
Okay, can
well,
we
we
go
may
back?
try... Let's get a Weiss needle. Let's just try. I'm 99% sure there's no pericardium here.
Okay.
I mean, for whatever it's worth, on the intracardiac echo, there doesn't seem to be much of any space at all.
No, there isn't. It's a good point. I can look around. There's no... I mean, what we really could do is obviously go through the through a cardiac vein and you know, puncture out a distal cardiac vein and try to inject. That's probably the best way. There's a lot of bleeding. There's a lot of bleeding from the puncture site that we had.
Yeah, maybe patients have pericarditis. And it's pretty.
Let's just have some towel there. Yeah. Yeah. Let's do this. Let's just get. Do we have a regular? Oh, this. I need a longer needle.
Okay,
There's like a lot of distance here. You know, it's probably going to take us a minute or two. We're going to try to get in the pericardium. If you guys want to wait with us, that'd be great. If not, I understand you can come back. Whatever's better for you. Yeah, that's a good one. Let's use that one. But I'm sure that I'm going to just puncture into the pericardium, though.
There's a lot of bleeding.
Yeah, this puncture site, I don't know why, but there's a lot of bleeding from the puncture site, even when I did the initial needle. It's really annoying.
Guys, we already consumed almost 20 minutes instead of expected 5 minutes.
Yeah, why don't you?
So
it's
we
okay.
should we go to the other room?
Yeah,
we can-
that's okay. You can go to the other room and then come back and we'll
No,
go a
but we
little
have,
further.
yes, yeah, we have some
Okay.
schedule. So
Yep,
No, understand.
sounds good. Sounds good.
Fair enough. Thank you for the timing.
Thanks. Let's. You got,
For cases that you guys done here?
No, 70.
Huh?
VT.
You're in 7-0?
7050 VT. And because we
750
no,
cases.
70.
70. Okay, perfect.
so that we can see you. We can hear.
Okay, so welcome back. Let me introduce the patient. We choose kind of a standard case of a post-MI patient. He's a 75-year-old male with arterial hypertension, kidney disease. He had in past ischemic stroke. He had many years ago posterolateral MI. He had treated with repeated angioplasty of circumflex artery, one of them being 2 weeks ago. He has for 2 weeks ICD implant by IV, and on echo he has an aneurysm of a posterior inferior wall. Has no thrombus. He has a standard care, medication for heart failure. Is no amiodarone. And if we move to the next slide, this shows you the VT that brought him to the hospital. It was under the arrhythmia, it was a ICD detection rate, which is about 140 beats per minute. And if you look at can we go back? If you look at the axis, it's from the inferior wall to 3 is negative. It's somewhere in the mid-inferior wall. We know it's a VT because it was one-to-one conduction at the ICD interrogation and was finally terminated by external shock. There is a tough kind of situation to programming the ICD. Can we move to the next slide? Because he also had, during the hospitalization, this typical atrial flutter with rapid ventricular response. So how you program the ICD if you have a very slow VT and atrial arrhythmias. So the plan is to treat both. Generally get rid of the slow VT as the first, but on the way out, because we are using transeptal approach, to also do the flutter line, which is very easy with the system and can be done within 1 minute. So I believe that's worth of doing. So maybe Joseph will comment what was done so far here.
We did transeptal access guided by eyes. We had to use we had to use this safe sept wire with nitinol tip because the septum was very thick. I could not get through, so we used that help of wire, and we entered the left ventricle. You can see on intracardiac echo there is a big scar with thinning, exactly how described Fermin in his presentation. It comes almost from the apex down to lateral wall. You see the hyperdensity, thinning of the wall, low motion of this area, so all signs of scar, which is quite extensive. You can see the scar also on the map. This is inferior view. Can you maybe put RAO on the screen and rotate? It comes to the posterior septum, but it's mostly a lateral scar, so maybe we can go to LL view. So this is the lateral view. If you rotate leftward, you see that it really covers most of the lateral wall from apex down to the mitral valve. We had very nice areas of late potentials and fragmented signals. Maybe we can show some of, okay. In the meantime, we did induction. We will show you these 3 tachycardias, which we basically
Can we go
induced.
the review screen on a big screen?
So this is one of them, which is to some extent similar to clinical tachycardia, but probably faster because,
subtle.
and it's
And
more
more
septal,
apical.
it's more apical. But we had 3 morphologies, all of them from the scar. This is also more apical and septal because there is a positivity in lead 1. And yeah, and this one is fastest. This was 250 beats per minute. And we had to shock the patient because there was no way to map. And we did some mapping of these late potentials, and we did some pace mapping also. So maybe we can show some of these late potentials. So you can see now on a running screen, you can see a late potential in D2, which is very, very long distance from the QRS complex. We can pace maybe D2. Can we pace
Můžeme
D2?
D2.
You see, this is coming to the valve. We did not see this tachycardia, but this could be the opposite end of the reentrance circuit. So if you are closer to entrance, you will get completely different morphology. This is a principle of some pace mapping strategy by Christian Deschillo, for instance. So if you have a very good pace map and very bad pace map, that marks basically this channel central zone of the circuit. But we can show you some other areas which
Review screen zpátky.
with pacing we resembled with morphology this clinical
Můžeme dát
tachycardia.
5.
This one is more resembling this clinical tachycardia, and that is the area in the scar on inferior or inferolateral wall. So then we induced tachycardia again, and we saw some diastolic potential. Here you see. It's not really mid-diastolic, it's a pre-systolic. And we wanted to do, because the patient went down with pressure, we wanted to ablate, but something got stuck with the system, so we had to shock the patient. And so we are in this stage. Patient has unstable tachycardias. We don't want to induce just for fun. We probably will start with modification of the substrate, and we would need to go across the whole area of these late potentials and fragment it. No tak. Dobře. Slyšíš to? Okay. Yeah. Okay, so basically this would be our strategy. If the tachycardia would be at least for a short period of time mappable, like I showed the case for HRS Summit, we were able to map at least some part of the channel. That was very nice because the patient tolerated at least 2 minutes the tachycardia. In this case,
maybe I will
not.
just add one thing too. We would like to now focus on the mapping, and the main reason is one way or the other we will use pulse field for it because it's a quite large scar. It would take forever to using RF, and with the pulse field, the strategy is that you should really focus on mapping first, because once you start to pulse, most of the local electrograms will disappear. We know that from Farapulse, doing pulmonary veins, if you do one pulse for the vein, all the electrograms disappear. Doesn't mean that you did it a good job. You do another 7 applications. In other words, once we start to pulse, we want to know what to pulse ahead before, and not just to do some pulses, some mapping, some pulses, some mapping. So I believe the strategy here is to be very clear what will be our target. That will include all of it before we start to use the ablation therapy, and then just do it and then see what's left and do the results. So I believe we will spend more time now for looking at these electrograms, just marking all the potential targets that we want to cover, not to be too extensive. In terms of the number of applications, we started usually with this Afera system low, just be afraid not to overdo it. But nowadays we usually end up somewhere close to the like 50 to 60 PF applications across the scar. That's, I believe, reasonably acquiring troponin levels for that, and that doesn't give you an excess. If you do it in the scar, obviously we won't use the energy in the high kind of amplitude muscle, because then would probably create really large lesions. But being in the scar, I believe that's a reasonable number so far. I know people use much more, but I would say to 60 is a good kind of target for the applications. But before that we start to apply, let's do a good mapping just to know what all will be the targets.
Also, important thing is that you should repeat like 3 or 4 applications on one spot to get the maximum penetration. That was tested and published in animal work from Ella Tanter. So we always do more stacking lesions. So you see now, if you can see the actual ECG maybe and the map, you can see that there is late potential up to here, to lateral part of the scar. I'm now coming towards the base. And there's again a lot of fragmentation, you see?
During the pacing and
And if you pace, it looks like there is only delayed conduction, but there is fragmentation. And if you pace, you have very long stimulus to...
slow conduction. So definitely that would be a target for ablation. We don't have a contact force kind of measurement. We do have some indirect evidence of contact by
You see
The
the
eyes.
by
They're not
obviously
showing the
eyes,
eyes.
but also on the catheter there are these white dots that will light up on the sphere and the 3D mapping system based on the local impedance that
Tell
you're in
them to show the
contact.
eyes.
But
Can you-
obviously, can you show the intracardiac echo?
So you see that the catheter is really sitting on...
Ano,
It's a
tak-
great location.
tak to
A co my
předej
budeme
nahoru.
dělat?
I love this location.
Můžeme... Tak Vivek bude
We can see the
Okay.
echo now.
Yes, so Fermin, maybe you could comment on that. Really, it shows the scar very well. And Yusuf, maybe you could give one for the audience. What is your recommendation for hydration? Because you're going to do multiple applications, right?
Yeah, well,
Generally, with the
Pre-hydrated.
Afera system, the hemolysis didn't seem to be an issue so far. Our data indicates compared to that, because the tip is not a kind of a large area like the Forapulse. It's a smaller, and generally the hemolysis was not an issue with this catheter. So in terms of, obviously it's a heart failure patient, so we don't want to really overdo it. But so far there was no kidney
That's
kidney
good to
problem.
know.
With this number that I mentioned, like the 60 to 70 PF applications, we
some-
haven't had a problem with the hemolysis.
Some people ask me if there is a problem with chordae tendineae. If you do transeptal, it's not a problem because you can always slide the sheath inside and get out. We had an issue with one case where we did retrograde in, was it Senning or?
Yeah, it was the
Senning
Senning.
case. So into systemic
Transposition
ventricle.
of great arteries.
And we get stuck in a trabeculae, and we had to do transbuffle puncture and grasp it through the opposite side, and then cut
showed
the catheter and pull it out. So that was a bit tricky, but generally it's very safe to map, and very nice manipulation with the catheter. It behaves like thermocool catheter, and the beauty of this rough surface is that it stays more or less on spot, so it does not slide too much, which is even better in atrium, because atrial wall is obviously smooth. But here you see also what Fermin showed you, that you have a lot of trabeculae and very uneven surface in the ventricle. So this is what
POSMI scar is usually smooth and very flat.
It's smoother, but
for a POSMI, this catheter is perfect. For a non-ischemic cardiomyopathy, some of the locations that might be tricky, especially close to the kind of hinge of the mitral valve or tricuspid valve, that might be tiny spaces when this bigger one will not go as deep as the 4
But
millimeter.
again, beauty is that you can map in the same time you can start ablation when you see some nice signals. So it really is much more, it's an advantage compared to mapping with some high density mapping catheter and then going there with catheter and doing ablation with a second tool. So, okay, so We can.
Let's do the map. Let's go switch to Homolka. Let's finish the
okay.
mapping. Let's mark the sites that we really
There
want
was
to do.
request from Homolka to be online, so we are switching to
okay,
them.
you can send. You can switch to Homolka, and we can finish the map and show you then ablation.
How much? 10 minutes? Okay.
Okay, so
Vivek
see
is
you.
in Homolka, is it? Yeah, I'll just feel the catheter once, but you should give me some directions.
Vivek, can you hear me?
I can.
Yeah, all right.
indeed.
Do you have any update on epicardial access or not?
Well,
Not yet?
so what we're going to do is we're just getting the equipment to do the pericardial puncture with, I'm sorry, to do a coronary sinus branch puncture. So we're just getting the microcatheter and a CTO wire. So, because I'm 99% convinced that there's no pericardial, there's no pericardial space. So I'd rather use that approach than keep puncturing from the pericardium with the bigger needle. So we're just trying to get that. So in the interim, they asked me to present a case that we did. This is actually part of the VCAS trial. So if it's okay, I can just spend about 10 minutes showing this case. Is that okay?
Yeah, absolutely.
Okay. And as part of this, there's actually how the Paracross device actually should work. So that'll be useful. So again, same technology. Oh, this is another advertisement. This case was actually, we showed at the PFA Live Case Summit, which, as it turns out, if you Google PFA Live Case Summit, you can access, because it was a very well-attended symposium. Anyway, so this is a patient, 76-year-old patient, as you see, with a history of myocardial infarction and reduced ejection fraction. And we saw him just, I think it was like a month and a half ago, and he presented with VTVF. Now, I should note, he's had multiple VT ablation attempts before, including attempts that included remote navigation as well as use of a lattice tip catheter. The patient was on amiodarone, as well as, of course, beta blocker, as well as other heart failure medications. And you can see he had a number of VT therapies, even from the last session, from February to April 11th when he got admitted. And a total number, now some of these are probably overcounted, but the fact is he had a number of therapies. This is a baseline QRS. It's a wider QRS, and you see evidence of Q waves in 2, 3, and AVF, inferior wall infarct, which is well known from before. This is the patient's clinical VT, which is also induced in the EP lab. And you can see it's sort of right bundle-ish, more positive across the precordium, positive in 2, 3, and F, but it seems to be coming from this posterior basal region, which can often be tricky. The catheter, the technology we've already talked about. The approach in this case was both transeptal and pericardial. The idea of pericardial access, I'll show you the images there. We did epicardial mapping, endocardial mapping ablation, and re-epicardial mapping. And so this is how the pericardial procedure should go when there's no adhesion. So, of course, you puncture with the needle as usual. I think this is actually playing in real time. The total time for this whole thing, as you'll see, is about 3.5 minutes. In the interest of time, I may skip forward just a little bit. Okay, so this is the tunneler with the obturator. So you'll see when the fluoro starts that we're pushing it subxiphoid underneath the sternum. This is a lateral view. Get past this anterior mediastinal ligament, and it's important to puncture through that. Once you're through that, then it's a very free space, and you're anterior to the heart. Then you lift it up so you're touching the myocardium, take out the obturator, put in the actual device itself. And here we typically inject just a little bit of contrast just to outline where we are. And I tilt it up a little bit. Then I like to preload the wire. And pushing this forward will access the tines. So I just pushed forward, the tines are there, pull back, and then that time I didn't like it because I wasn't holding on tight enough. So next time I push a little bit harder, advance the tines, pull back, I still have the pericardium, which you can feel, advance the needle, advance the wire. And once the wire's in, so this is a 014 guide wire, and we'll go LAO, and in just a second, you'll see the guide wire here in the pericardial space. We really like to push it further to make sure we're, really in the, that we're not just in a big RV. But in just a second, I think the wire will end up going to the left side also. And there it starts moving further. And then we advance this other dilator in. You can take out the wire in the smaller obturator, and now you can put in an 035 or 032 guide wire. And of course, then you have pericardial access. Okay, so that's how the procedure works. Now, let's coming back to this patient. The first thing we did was to map the epicardium. So here we're using a DECA-nav catheter. So again, we're using the Cardo system, and we're manipulating the pericardial space. This is sped up here, as you can tell, 8x speed, just in the interest of time. And if you just look over here, you can see that right around here there was some late potentials, some fragmented potentials. And you can see this relatively large inferior posterior basal infarct. Well, low voltage, let's call it, to be a little more accurate. Again, this patient had a number of previous ablations, remember. So with that, a lot of the scar area was very homogeneous, nothing that terribly interesting. But in this location here, you can see some late potentials in the pericardial space. This is looking at activation. Let's just jump forward a little bit. Again, you see these late potentials here. Let's position a different perspective. And of course, when you're moving it around, it causes a lot of artifact. And I think that's about it. Yeah, and here again, you can see fragmented potentials when we're not moving, and late potentials. Okay, so that's what's there, and you can see the activation is late in this location. Fine. Then what we do is, and this is just the scar itself. You can see this large area on a voltage map with the 0.5 to 1.5. Here it's a little bit more wide open. And here's an activation map, again, showing this late activation and some potential areas of block. And this is just looking, again, in regular rhythm. It was not using S3 mapping. Then we do endocardial mapping. So here we used an Octaray type catheter. And you can see, again, a very large inferior and posterior basal scar. And you can see all these late fragmented potentials here. And that was really located in this region here. If you look in other locations, it was relatively homogeneous. We also did some S3 mapping, as Ivo was just talking about. And you can see over here, it can just make it out. Very late potentials. Really, with S3, they really popped out. So this is, again, the voltage map, endocardial voltage map, very, very large. And really, it was in this location here, or I should say here, that we saw these late potentials and fragmented potentials. And you can see, again, this area of functional block. Let me just play this. This is the epicardium. This is the epicardial late potentials and fragmented potentials. And you can see the area looks like here of block, whether it's functional or otherwise. Then if you open this up, you can see the endocardium was just underneath there. Let me just show that one more time here. And here, this is the endocardial. A lot of these are endocardial potentials. Okay. And again, I already showed you how we annotate this in order to target for ablation. So we manipulate the catheter. If you look at the catheter, you're going to see it right around here in this location. So we're only going to ablate endocardially in this patient. So we put the catheter here. You're going to see the pulses here. That's one application. Okay, that's just an artifact. That's a second application. And you will see microbubbles here, but these are high frequency, high amplitude, but also very short pulse width. And so we do see microbubbles, and we believe these are all just electrolysis. We don't think this results in any heat. That's based on preclinical and benchtop work. So these are the applications that are delivered. Oh, let me just go back here. So after endocardial ablation, we take the catheter back, and now we're going to remap the epicardium. And you can see a lot of these late potentials that we previously saw ended up being eliminated. I'm going to jump forward here in the interest of time. And again, you have to wait until the catheter is still, because as you move the catheter, there's a lot of artifacts, obviously, that are occurring. So just jump forward here. If we come, okay, just sped up here. But anyway, all of this epicardial previous late potentials ended up becoming homogenized. So this is the final epicardial voltage mapping. Again, it doesn't look that different than before, but the point is it's really homogenized. And then we remap the endocardium This is again using the octray and the endocardium. And again, all those late potentials, et cetera, in this location are gone. And you see the constellation of lesions that were placed here. This is the final lesion set endocardially. This is the unipolar voltage, just a little bit more wide open. So ultimately, in this inferior wall with some septal extension and posterior basal extension, you saw we did a total of 20 endocardial lesions. This did result in epicardial electrogram elimination. The transport ablation time was 24 minutes. Again, for such a large substrate, we're pretty happy with how quickly and efficiently this is. And again, in this patient did well without complications. And now it's been, I think about 6 weeks or something, and the patient has had no VT, which I know it doesn't mean that much, but the reality was he was having daily VT before the procedure for over a couple of weeks. So we feel pretty good about this patient. So hopefully that was very clear. I don't know if there are any questions about this case.
Are there any questions from the audience? There are none.
And everyone's either dumbfounded or bored. I can't tell which.
What about myorelaxation? It's probably essential in this procedure because probably the body movement in non-relaxed patients would be even higher than in case of standard PFA.
Yeah, no, absolutely. Look, we're doing, this is high energy and monopolar pulses, right? So we're using surface patches. So definitely we get significant muscular contraction. So we did use relaxation in all of these cases. For some of the atrial work, in fact, we're going to show an atrial ablation case tomorrow. There we're doing both unipolar as well as bipolar. And eventually the expectation is with bipolar, we're not going to need to do that. But again, this is work in progress.
There is one question from audience.
Energy delivered fixed, or you can somehow play with the settings of the energy delivered?
Yeah, it's a good question. Right now, by protocol, it's reasonably fixed. So we deliver 5 applications over successive heartbeat. One lesion is 5 applications. You saw each application is basically a couple hundred, less than 200 milliseconds. So instead of 5, if you want, you could deliver 4 or 3 or 2 or 1. We know from preclinical work that with 1, you get a certain depth. With 2, you start increasing, and it starts plateauing somewhere between 3 and 5. The reality is that I do think that in the future, we will be able to vary the amplitude, which is probably the most important variable for this particular technology. At this point, it's a relatively fixed recipe. As you'll see tomorrow, for the atrial cases, we don't do 5. It's really a single application. Each location, that's the lesion. So you go, boom, next location, boom, next location. So that's a completely different workflow because obviously in the atrium, the tissue is much thinner. But in the ventricle, I think we need to learn more.
All right, so I can't see any hands up. No more questions.
Great.
All right, Vivek, thank you very much, and we will switch back to the ICAM.
Sounds good.
Můžeme tu první aplikaci ukázat předtím a potom. Ukázat signály předtím a potom po té první aplikaci. Před tou první aplikací a potom zase Wi-Fi. Ještě zrychlit to na 200.
Peter, can you...
A review na velkou.
Welcome back. In the meantime, we started ablation. So Peter want to show you some phenomenon which we are looking for now.
Looking at. So first, we started to the lesions. The aim is to go from the apex to the base, make a line, transect the scar. But before we really proceed with that, just let me show you the first lesions. Can we go to the review screen? We started somewhere close to the apex. We don't want to do these applications in the healthy tissue. We want to focus on the scar to do the minimal damage. So if you do review screen on the PRAGUE, so can you switch to the review screen on PRAGUE? So we're waiting. Sorry, it's just the plan was to. So we will have it the review screen for PRAGUE soon, or should I talk? Okay. So generally, okay, it's already there. So can we go to review screen and show? So hopefully you can enjoy these electrograms that are shown there. Okay, so there's there was from the different lab. Generally, so I'll explain the problem or the concept. So we make a first application. Obviously, the electrograms will disappear, which I'll hopefully show you in a minute. But there's the other thing. During this application, this is 5-second application, and there are 12 kind of short pulses. They're just separated from each other, and those pulses can work like a pacing artifacts or pacing kind of capturing the myocardium, and you can see that during the application. We're still working on the review and just looking at the sculpture, you can somehow know something about the lesion. In other words, if you have a catheter on a non-excitable tissue, you won't even have a capture. So if you ablate, there is this irreversible zone, there's the reversible zone, and there's this capturing zone. So if you don't even capture with your pulse, generally it means that the tissue is completely unexcitable, and it's probably going to be, you can move on to the next site. So how we are with the review screen to show?
We can do it live now. We can do ablation now, and you will watch if there is any. Yeah. Okay.
Okay. So let me just show it on the camera, or just I don't know why that's.
Okay. Can I ablate?
Technically, it's my presentation crashed.
Can I ablate?
You can ablate, obviously, but. So this is how the application is. There are 12 pulses of pulse field energy during the and we have some arrhythmia induced. This is not a sinus rhythm, so can we map?
Oh, we can map this one.
So some irritation might be. It's very slow. It's slower and slower. The question during my presentation is whether we see some acceleration of the arrhythmias. No, but what you see sometimes when you pulse in the scar, that you have this accelerated ventricular rhythm. So do we have the review screen already? So can we switch to the review screen? Okay, guys.
It's showing some rubbish there.
Okay, so maybe switch back to I mean, we'll show the just series of applications. Can we switch back to the kind of Afera screen? Okay, so let's continue with the therapy, and we will explain the things about the application later on. So yes, please go. Honzo, řekni mi, až to bude fungovat, jo? A nehodlám tady. No, perfektní. Okay, so can I just show the audience the application? So can we go to the first application to see the signal before the application and after, just how it changes? So go before in the review screen, go to 200. Okay, so hopefully you can appreciate now that there are a lot of late potentials. This is the site that we really want to target anyway, irrespectively, because this is a very slow conducting tissue. This should go away. So we did the application. Can we go to the right to see that this is the artifacts? You don't see much, but after the artifact, if you look how the signals will look like, can you go to 100 again? Most of them are disappearing. There's not much there. Can you slow down to 50 and show the application itself? Go. Okay, so application itself to the left. Okay, even slower.
25.
Okay, can you increase the gain on the blood pressure? So there, this is the 5-second application, and hopefully, if you can see, there is the blood pressure which gives you the idea whether the heart contracts or not. And if there is a kind of healthy tissue, each of these 12 pulses over the 5 seconds will give you a contraction. So you will have, hopefully now you can see, this kind of bumps of the blood pressure. Generally means contraction, opening of the aortic valve. Can we go to number 2 and number 3 the same way we did? We already, by gradually increasing the number of of applications per site, you're generally losing this because you're making the tissue inexcitable. Generally, meaning the reversible zone was beyond the excitation zone, let's say. So generally, if you see kind of gradual losing of it, generally meaning that you're doing a lesion. So there's a kind of novel way how to assess what you're doing and whether that you did this kind of application make some changes.
It seems to me that it works pretty well if you have transmural scar and only small channels. If you have subendocardial scar, you always capture
because
outside
the myocardial
of the scar.
is always on the other side, which we always capture.
You can't use it in subendocardial, but here we have really a very nice mature scar, so it may work here.
It also works in the ARVC in the right ventricle when the myocardial thickness is. So generally it tells you that the lesion is transmural. The optimum would be like you do the pulse and there's no capture whatsoever, generally meaning there's no reason to continue with the application.
So it's nice. It gives you a electrically unexcitable scar is confirmed during ablation itself. It's very nice.
So can we continue? Because the pacing here is not very reliable because of these microelectrodes. So let's continue. We will stack the lesions on one on the other. You can look at this capture now. There is some intermittent capture only.
So can we show this application, for example? This was a good one because as you can see, there's virtually no capture or very few capture, maybe 1-2 captured beats. So if you're in a review screen, so generally it means that we are working in a dense scar and there's not much surviving myocardium. Can you go back to the big Affera screen? So our workflow currently is to make that up to 4 applications per site if we believe that we need more. Probably there's not much sense to do more than 4 applications per site. And if you really want to, and kind of, it's somewhere in deep, the channel is there, still there because the VT is still inducible, you can combine with pulse field and RF. And that would give you probably the highest chances to make the most of the depth of the lesion. On the surface, you can stack those lesions, so the surface will be covered. It goes pretty quickly, but to the depth, you probably have to stack those lesions, but also maybe add the RF lesions. But the RF lesions we save for those sites that probably are still kind of deeper substrate and the combination. We have in Europe setting for RF, which is slow cooking, 40% of the maximal output up to 30 seconds, up to 1 minute. In US, that is not kind of approved. So in US, the only way the RF can be used in the ventricle is to use this 5 to 7 seconds application short, which probably won't give you the deep lesions. So probably in US will be better to use pulse field. Here we can choose. I generally consider non-thermal a kind of safer way how to... Máme strašnou hypotenzi.
We have some hypertension, so we have to increase those.
Můžeme asi teda ještě zapnout ten bive a zrychlit ho, dát mu nějaký atropin nebo něco.
No, prostě biva,
nebo něco mu dát toho biva, pustit na rychlost. We will just activate the BIV pacing because we already set the kind of, we already saw all this one, the late potential, so we...
Peter, while you're continuing, any comments on the assessment of durability? I mean, in the atrium, of course, we've come to understand that it's very hard, that we have no good endpoints for assessing durability acutely. And would you say this is the same in the ventricle, or perhaps this loss of capture, as we just saw? Do you think that's a reliable marker of durable lesion formation, or is it the same issue as we face in the atrium?
The problem is that you never will probably get completely transmural lesions, so and it's probably not needed in most of the cases, because especially in post-MI you have subendocardial scar or mid-myocardial scar, so I think it's very difficult task. The only way I see would be that you do core isolation and you come back 3 months later and remap if there is still core isolation. But otherwise, I don't see the way how to check unless you follow the patient if there is any recurrence, or maybe do some nips afterwards to see if there is no inducibility after this initial ablation, because you do a lot of, you touch the tissue, etc. So maybe a few days later do nips would be another way how to somehow estimate that your lesions are okay. But it's more difficult than in pulmonary vein isolation, obviously.
Because of the depth, it's very difficult to assess in a clinical practice how, because the non-capture of pacing, which we demonstrate using this, we try to assess this, we try to see whether this will work in the RV, LV, in the dense scar, in the subendocardial scars. But I believe it's an interesting phenomenon because and it's definitely something worth to follow and study, because it just gives you some feedback during these applications. And to be honest, for some of these, for example, RV applications, we ended up with the pulsing, but having no opening of the aortic valve, so generally no capture. Generally, it means you should move on. There's no reason to do more lesions in there.
I think we started with pacing because the patient had lower pressure, and we managed to stabilize the patient.
We
so
also have we didn't give probably atropine, which is important for these patients because otherwise you stimulate the vagus. So that's why we had a hypotension. Now we activated and we give atropine, so we have now good blood pressure. So the idea is obviously to connect towards the mitral valve, because that's most of the channels are going one up, one down. So this would be a kind of strategy now. Obviously, the mitral posteromedial papillary muscle is in a way, so we have to somehow manipulate around.
On ice, you see it looks like it's floating, but it's attached to papillary muscle, you know. So I'm pretty confident that I'm touching papillary muscle. It's moving with the papillary muscle, so it's not really outside. So I can attach to the wall because we are close to papillary muscle.
Yeah, it's moving with that.
Yeah, so it's moving with papillary muscle. Let me see. We are stuck now in Cordy. Can you show this?
Okay, so now we are on the top of the papillary. So now we moved.
You're on pulse.
Now we moved.
Is it pulse? Okay.
Maybe I moved. We moved a
okay.
lot.
Oh, sorry, I did not.
So generally is to follow and stuck the catheter underneath the mitral valve, but on the way there we will do the ablation along the papillary. So now we are in the posteroseptal region. Can we do RAO? This looks like a more healthier tissue, but maybe we just go more to the mid part of this.
Can you elevate?
We have some preliminary experience with the ablation of the papillary muscle ectopy with this system. The logic there is it's much easier to stabilize the catheter for 5 seconds rather than 1 minute with the RF application. And so far, because of the larger footprint of the catheter, we try to do a kind of very focal, localized ablation, and so far the results, we were able to treat patients that failed previous procedures, even with whatever tried. So far this looks also very promising. Obviously more is needed. The one problem with the ectopy on the papillary muscle is that we usually use general anesthesia for Afera system, and when you put the patient in general anesthesia, you don't have any ectopy. So the way we currently use for papillary muscle ectopy ablation is that we just map everything in unconscious sedation, and we just make the part that we want to ablate, then we put the patient asleep, and then we ablate with this, and then to see also whether the arrhythmias will come back or ectopy will come back after the patient gets out of the anesthesia.
This is nice. We are pacing from this posteroseptal area.
So we are now underneath the papillary muscle in the thin part of the myocardial. So this would be
okay, let's go
just
here.
push more a little bit more in contact.
I'm pushing really. Yeah, it's on the.
Okay, so go here.
See, no capture, almost no capture. So it looks that we are doing well.
Yeah, this is a good one.
And can you comment a bit on the contact? I mean, you can see the contact very nicely, of course, on the ICE image, but do you need to try to really generate strong force, or is contact enough?
No, I don't think we need to measure contact force. If you have good contact, you see it on ice.
And EGMs too. So
and EGMs. Also,
Yeah,
they
yeah.
are very crisp if you have good contact. Can we see again inferior view?
So yeah, the contact force measurement is not provided. It's just a contact yes or no. But I believe what we know from it's a large antenna, and generally if you put more contact force, you make the whole sphere more compressed. So I believe that just contact is good enough. We don't have to really go for the contact force 5 grams, 10 grams, 15 grams. At least we don't have the chance to measure, but so far didn't turn out to be the most critical part of it. So we are just working underneath the papillary, and we obviously move towards at least 2 or up to 3 applications per site. So that's it. And also, yeah, that's a good. I have a hint from the technicians that during the applications, maybe Kuba can show on the screen of the Afera. There is although it's non-thermal application, there's sometimes a rise of the. Actually, you want to have at least 1 centigrade increase of the temperature, which generally shows you that you are in contact. Because if you pulse in the blood pool, there's no temperature rise at all. This 1 temperature Celsius increase is not probably thermal, but it just gives you a feedback that you do the correct application. Kubo, can you show some of the applications when we have a temperature rise? So maybe just to demonstrate for the audience. So okay, so maybe if I don't know whether you see it in the lower part you can see that there is a kind of this orange, or I don't know what the color is, yellowish color, orange color. There's an increase of the temperature during the application. So we started we go up to the 40 degrees, but we started somewhere at the 35. So generally, if you have this kind of increase, it gives you a feedback that you were in contact, because this doesn't happen in the blood pool.
So we are still moving within these areas of potentials.
So the manipulation around the papillary, I believe it's still safe to do. It's not like dangerous. Don't get
Can we
scared
try to pace from T?
of my presentation, but it just says that you should be careful, and if you feel that the catheter doesn't move, you just have to put back into the atrium and
full output.
Yeah.
Oh, okay.
You're not giving the
Usually there is no capture. Even I believe the non-capture using conventional pacing is a very poor kind of surrogate of the lesion if you use pulse field, because universally there is no capture after 1 pulse field. Okay, and now we will go back to the. So also the system marks some of those points, as you can see on Afera. Some of them are green, some of them are like a blue, and the blue ones were generally set by the system that there was no good enough temperature increase, which might be because we are touching the papillary muscle only on the side, not with the contact with the inferior wall. What you also can see maybe on the live screen is that there's some kind of activity, ventricular rhythm after these applications. That was described by Andrea Sarkozy paper, that this is quite common. They, I believe, had it in 40% of patients. Usually self-terminating, it lasts for 10 to 15 seconds and then it disappears. It's slow rhythm just because of the kind of excitation by the pulse field. So far, I really didn't.
It slipped back.
The RF lesion is more or less the same. It takes only much longer, as we know. Obviously, the temperatures will be much higher. So maybe you can review. We did 1 RF lesion in the kind of apex. So can you go and show maybe the temperature increase? So yeah, how to adjust. So if you use RF, you can see that the temperature goes up to how much?
More than 50 was
57 degrees. So generally, it's a thermal lesion. The system tries to optimize the energy delivery based on 6 thermocouples there on the surface of the sphere, and somehow modulate the energy delivery based on the temperature. It sends not only the absolute value, but the system also looks at the steep slope of the increase. If there is a sudden increase in the slope of the temperature, it down-regulates the power. So it's like temperature-guided RF ablation.
So RIO and elevate.
Yeah, this is a new spot.
We have still scar
So
here.
there's a question from the audience, if I got it correctly, which was, what is the reason or the motivation to do the RF lesion in this location? Is that correct?
Generally, the apical RF lesion was done to test because we had some technical issues with the initially with the generator, so we wanted to be sure that for the live transmission we'll be ready to do what we want to do. So there was one short RF application just to test the system. We started with the RF applications with this system nowadays, especially if it's a large kind of scar. I'm more to use pulse field because it gives you, it's much faster. Within few not minutes, but in a much shorter time, because these are 5 seconds applications, you can cover and bombard if you decide for a scar homogenization. Especially for a larger scar, I believe that might be a strategy to, obviously, we want to do it only in the scar tissue, not in the healthy myocardium. So we're still missing the part close to the mitral annulus, so we have to obviously close that gap, but we want to make sure and stack those lesions. So we currently have about 30 lesions, so about more 30 to go, and then we maybe retest and remap whether we will see still some interesting potentials on the kind of boundaries what we've covered and ablated. It's a very straightforward kind of approach. It's not that sophisticated, I would say, but still, it's something that so far works pretty well. Okay, so maybe we can switch to the next lab. No. The next lab is ready to show you more sophisticated stuff. So it will be Ivo.
We are now close to the valve.
Peter, can we switch now to the
This
other
is amazing.
ECAM EP room, or or do you have any? Because Ivo Roca is ready to present her case, his case.
Okay.
Can
just
you
a
hear
second.
us? We can see you.
Yeah, we can hear you.
Yeah, perfect.
Okay. Okay, greetings from EP Lab 3, from ECAM. We are here with Professor Ivo Roca, and today we will present you a patient where we are planning to do substrate mapping and VT ablation using S3 protocol, and that is guided by CT imaging. Next slide. So this is a 74-year-old patient with chronic heart failure. He's now stable. He has a peripheral artery disease and he has a coronary artery disease. And the first myocardial infarction this gentleman had in '89. No stent was implanted at that time. So in 2019, he was presented again with STEMI of the inferior wall. And initially, he was presented with sustained monomorphic VT that was cardioverted. On the coronary angiography, there was a multivessel disease, so this patient underwent first surgical revascularization. And at the same time, he had the implantation of the epicardial LV lead because of the sinus bradycardia and long PQ. After revascularization, we did a programmed ventricular stimulation where fast monomorphic VT was induced. So this patient underwent CRTD implantation as a part of the secondary prevention of sudden cardiac death. And this is his echo, so mildly dilated left ventricle with a decreased ejection fraction and with akinetic inferior wall without thrombus. So next slide. This is a VT that was induced during the program ventricular stimulation in 2019. So we see the fast monomorphic VT coming from the mid-inferior wall. Next slide, please. So, and during the follow-up, this patient had some interventions, but he was asymptomatic. But most recently, he had several VT episodes that was terminated by first ICD shock. So he was scheduled for the VT ablation. Okay. So can we see now the echo screen, the eye screen, please? Do you see the eye screen? Okay. Here I will show you just how the LV looks like. So here you can clearly see the presence of the maybe almost transmural scar on the inferior wall going from the annulus to the mid segment area, and you see the whitening, the small whitening on the this inferior wall. This is epicardial lead that was implanted during the surgical procedure. So, and the rest will tell you maybe Ivo.
So hello everyone again. I could say that I'm extremely happy because I think we have seen very nice things. So very good job. Very good team here in the lab. So I present you Judith. Judith is a Spanish Abbott FTE. So Judith, can you show us first the CT, please? Can you see the inside system? Okay, so this is the CT. It means that in red it's wall thinning. Less red it means a bit thicker, and blue is healthy tissue, or less thin. And you can see that there are areas that are channels automatically detected by the system, by others, that are crossing areas of very wall thinning that are a bit more preserved. So potentially these are areas that could be with a slow conduction. So what we have done is we have done a conceptual approach, and we have done the S3 map. So can you show, please, Judith, show us the voltage map, please. I don't look. We have look at the voltage map at the end, but just to show you. So this is the voltage map. So this 0.5, 1.5. So probably nothing more than scar. Can you decrease? We never use the voltage map, but just to show it, can you decrease the low? So it could be a channel inside heterogeneity, so not easy. But can you show us the S3 map again? Remember, the S3 map that we have done, we calculated the refractory period, that it was 290, so we have put it at 310 and 340. So this is the map with the 340 milliseconds coupling interval, okay? And you can clearly see two areas. One area, yeah, no problem. So this is one area here where I am now with the catheter with a lot of colors. At the exit of this channel of the CT scan, you see a lot of colors. You have to remember that when you're using ILAM, every color it's the same time. So if you have a lot of colors all together, it means that the wavefront, it's taking a lot of time to cross that area. So this is a slow conduction. So this is one area, and the other area, Judith, can you show it in the most posterior septal area? So this area also with a lot of colors, okay? So like 4 or 5 colors with these pink potentials. Can you show, Judith, in the inside some signals of both areas? These channels are the CT channels, so it correlates pretty okay. Okay, can you see the signals that are nothing in S1? Can you, okay, put it, okay. In S1, you see almost nothing, Judith. Can you, with the mouse, okay, nothing in S1, or almost nothing. In S2, delay, and in S3, a bigger delay. Can you go to another area, Judith, to the other area, to show another signals? Okay, look here, again. S1, almost nothing. S2, nice things, and S3, nice things. Okay, so before going to the EGMs, can you propagate the map, Judith? So again, it's a propagation of a S3 map. So you will see that it looks like a re-entry. Can you propagate? Okay, this is a propagation. So we are pasting from the RB, and you see a clear area of a slowing of conduction here, like a figure of 8, almost a figure of 8 here, and it's not a BT. It's the S3, okay? But it's clear that there's a slow conduction there. Can you rotate to the posterior septal? Okay. Also a re-entry there during the S3. So it's clear where we should have to ablate. And the patient has been with 2 VTs, I think, today.
We actually had 3 of them.
Yeah, 3 VTs. Can you show the first VT in the PRAGUE, please?
Yeah. Put the PRAGUE on the main screen.
PRAGUE on the main screen, please.
Review.
Okay, this is the first VT. Okay, so almost left Van der Waals block, but early transition, intermediate axis, positive 1 and L, so probably septal. Can we, so this area, can you show in, this is VT1, can you see the, but what we did is we put the edge grid in that posterior septal region.
Dovnitř.
And you see the mid-diastolic area. And this is the area Judith showed is the posterior septal region, the other one. So we couldn't map because it was non-tolerated. But this put the S3, Judith. Okay, so put again the S3. So where we saw that diastolic potentials, it was in that area of posterior septal area in the S3 that I showed you before. Can you see how this BT stops, please?
Number 4.
Number 4.
Number 4. Yes.
Look how this BT stops.
Amazing.
So we have mid-diastolic potentials, and there is a clear block from the diastolic potential through the next QRS. Can you highlight with the mouse in the red? Exactly. So there is the diastolic potential and no more QRS. So it's clear that the BT stops here from the isthmus to the exit side. So we proved that in the posterior septal region there are diastolic potentials. So we induced another BT. Can you show the BT2, please? BT3, sorry. Yeah. Okay, this is the BT3, okay. That it's 12 VDCG, please. Okay, so this is right Van der Waals block, so more lateral. Axis it's also intermediate, negative in 1 NBL, so this is clearly more lateral. And when we put the catheter in the other area of S3 lateral, can you show the diastolic potentials here? In the white ones, it seems like they are 2 to 1, but in the red ones, they are really consistent timing in that area. Okay, and that area was the second area that Judith showed you at the beginning. Can you show the local reentry here? So we induce a BT again here of the BT1 in the posterior septal. Sorry, we induce just a BT in the posterior septal doing S3, so the first BT, and look, can we go to the left? Okay, so we're placing S1, S2, and look that in the S3, the red EGM is really delayed. Now it's after the yellow EGM, and there is a local reentry producing a beat of the BT1. So another proof that this area is critical for reentry. So we have proved that in the two areas that Judith will show you now. Can you go back to the end side, please? Yeah, S3. So that area that, posterior septal, Judith. So that area that we showed you, the BT1, is that exactly that area in the S3. Can you propagate again? Okay, so again, doing S3, it mimics a BT here, like two BTs, one in the posterior septal, that's BT1. So it's not a BT map, but it looks like a BT map. And here we had diastolic during BT1 and local reentries. Rotate to the lateral piece. And the BT3, we had diastolic potentials exactly in that area that it's always mimicking a reentry during the S3 map. We also induced a BT2 that probably it's Van der Waals reentry. Can you show the BT2, please? Very fast BT. We didn't induce it. It was also spontaneous.
So during the mapping, we had this with...
So this is probably a Van der Waals reentry, so probably we will ablate also the right bundle. So what we could do now, if you want, is we can do some pace map here.
Yeah.
Okay. So we are in the probably the exit of the BT3.
We have ectopy actually from the catheter.
Exactly.
That resembles the morphology of
so
the BT.
So can you put in the screen the BT3, please, now? Like two screens? Like two windows? Okay. And now the actual window just to
review.
Exactly. Review. Exactly. Okay. And now we can do some pace map here because probably we will have like long steam to QRS and good pace map.
Put the VT3 in the review window.
Exactly.
Great.
Yeah. Okay. So we can now do some pace mapping from the ablation catheter to check the morphology. Can we pace, please? It's capturing now. Can you show what is the score, Judith?
Very long S to QRS.
Very long to steam QRS. So again, nice. So the score, you can see the inside. You see in the inside the score, you did show us. So now you have here that we have 94% long to stim 2 QRS, nice S3 potentials during S3 mapping, and nice diastolic potentials during VT. So
Amazing.
we have enough clue to ablate this area. So our strategy now would be to ablate that area, and then to ablate the second area,
Yes.
and then remap. Judith, can you please show us where are in the city?
Can you note this as a good pace map, please?
Yeah. So we are at the edge of the scar, at the exit of that channel. So probably what I could do is now go back to the S3 map. I put a marker of the area of interest, and then I will homogenize both areas. And after that, I would remap again with S3. And if it's clean, then I would induce.
Yeah.
And when? Right bundle range. Right bundle
Can you just explain the ablation setting for this?
Yeah. So Judith will put a marker. We are using AG Grid X. AG Grid X, it's like the conventional AG Grid, but with two sensors, one at the shaft and one at the tip. It means that you can collect anatomy more carefully because you don't need to shave almost anything in the anatomy. Judith is just shaving a little, but nothing else. And then you are using Tactiflex. Tactiflex, it has contact force, and the good thing of Tactiflex is the stability. Even during ablation, you will see, because it has sensors at the tip. It has a flex tip. Then you adapt a lot to the tissue, and you can irrigate at 13 ml per minute, even when using high power. So that's if I have like 20 grams, I would start at 30 watts more or less, and I would look at the impedance drop. So I am aiming for a 10% more or less impedance drop. Obviously, if you have the ice, but you have another clues, but I'm not used to the ice. So Judith, can you put a marker in the area of interest? Yeah, from the blues, dels vermells als lilas. You see that we are merged, so we have mapped only the area of interest. Okay, exactly, up, okay, up. See? Up, yeah, and then up. No cal, fins allà no cal, no. Dos àrees separades. Here, and here, okay. And then the other area. Yeah, scepter one. And again, this patient has 4 channels, but 2 of them have no slow conduction. So we will ablate just the channels with a slow conduction. Okay? Okay, compensation. Okay. Any comments from the audience, from the panel? It means that you are sleeping or everything is clear. Hopefully the second answer is correct.
I have a comment.
Okay.
I'm actually really amazed by this strategy of functional mapping of the substrate. This is really amazing because during the pacing rhythm we haven't seen any potentials, any late potentials, but with this functional mapping we revealed areas that can be like overviewed, right? So this is amazing.
Yeah, I think, and it's easy to do. I mean, you have never done it before, the S3, and you have done it really extremely fast, much faster than myself. So I will send the patients to you. But I think it's a clear idea if you propagate the map that it's like 2 VTs going together, that obviously it's not possible, but it's local delay again. Judith is showing you again. So it's clear where to ablate here. So you don't need any color, so you would ablate from here to inside and the other region. So, and again, it's a mixture of structure and function because there is a scar all over if you put the propagation, the voltage map, but the main area of the delay, it's not in the middle of the scar in this case, it's at the edges. That's 50% of the cases. So probably we could start ablating here. Judith, can you show us?
This is a nice signal.
Yeah, look the nice signal during biventricular pacing. Probably biventricular pacing here, it's not the best because you're doing 2 collision, but you will see that with the Tactiflex, that signals are not disappearing because of noise. Okay, I have the ablation here.
Another advantage of this strategy is that we didn't have to induce tachycardia, right? Because this patient is on a vasopressoric drugs.
Exactly.
So we have
let's
a stable
see, we can start
hemodynamics.
ablating here. Impedance, it's 100. Okay, do you have 30 watts, 45 degrees? And the cool point will increase to 13 only? Okay, great. So we could start here. And let's see if this 10%.
Okay.
It's the ICD now.
Inhibiting the pacing, right?
Okay, but you see that there is almost no noise during ablation.
Yeah.
There is so we decrease to 12%, so we probably end at 30 seconds, enough probably here. You see a very flat curve of impedance, so very stable position. Okay. Why it stopped the ablation? I don't know why. Okay, okay, great. No, it's okay. 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 Okay, again here.
It's a really flat area here.
Yeah, okay, great. Can you show us the voltage again, Judith, because just for those who want to see it.
Hello, may I ask a question?
Yeah, sure.
I wanted to ask two things.
again?
First, can you please comment on the power you use? I think you said 30 watts. Is there a specific reason why you do not use 40 or even 50 watts? And the second is how you titrate the length of the application. Is it just based on the impedance? You look at the signals or a combination of these?
Yeah, very good question. First of all, here probably, Judith, can you show the wall thickness and increase until blue turns in red? So this is 7.8 millimeters in wall thickness, so that's a clue. So 7.8 probably it's enough. If you have good contact, 30. Probably now we have less contacts, 5 grams, so I will increase to 40 watts. And if the impedance drops, it means that you are creating some lesion. So why 50 if the impedance doesn't drop? If you are not decreasing the impedance, then you can increase to 50, for instance. But here, let's see 40 watts here. Why it's cutting the ablation? Why is cutting the ablation here? I ablate and it stops. I don't know. I cannot ablate here. Probably some. Okay. In the meantime, before you fix this, can you go back to the EGMs, please, because we can show some to the PRAGUE, please. PRAGUE. Okay. In the PRAGUE now you have an example of clear hidden late potentials. Because in S1 and in S2 you see nothing, and in the S3 you see those very nice late potentials that you would have missed with S1 in this area. I think we have more here. We have more. Can you show more examples, please? Another. That's very nice. That's very nice example. Look in the white spline. There is nothing in S2, nothing in S1, and very nice late fragmented late potentials. So this was hidden if you don't do the S3. So it could be that this is not critical for 1BT now, but it could be critical in the future. Yeah. And there is another nice potential that we call it like fragmented, like hidden fragmentations up. Yeah, exactly. Look at this one. This is not hidden because you see it in the S2, but look how many delay there is between S2 and S3. And there is another one up. Hidden fragmentations, another example, please. Exactly, here. Look, show the S1. In S1, you see something in red, but you don't see nothing in the yellow spline. Can you show them, please? Yeah, exactly, or very small. And then in S2 and in S3, you see a clear increase of the delay. So this is a critical area. Judith, in the meantime, you can do the turbo map of S1, probably. I cannot ablate. No, I'm not ablating. Now? Okay, now.
Okay.
Yeah, I'm ablating. So can you please, Judith, do the turbo map of the S1 to show them the difference between S1 and S3?
Yeah, ask directly.
Okay. Temperature is increasing, so if it goes like that, we will increase the irrigation to 17 or so.
Is ready for transmission, so.
Oh, we can switch if you want. Whatever you want. Okay. You can do turbo map in the meantime, Judith, don't worry. Vale.
Yeah,
so now it's the boring part.
You should repeat because they didn't capture your.
Sorry?
Yeah, there was question, please.
Okay, yeah, sure.
We don't hear you.
We don't hear you. Okay. Go to 30 watts here. Have a lot of contact now. Okay.
Try this.
So the question was, how often does it happen that when you, with the S3 protocol that you will simply induce the VT? And if it happens, how would you modify the protocol? Another question is, how would you annotate those late potentials in S3?
Okay, great question. So to the first question, when we analyzed that in the S3 protocol, we proved that in 85% of the patients you can do it without inducing. The exception is patients with VT storm that you induce a lot, then probably I would stick to S1 or S2. And if you induce a lot, what you could do is to increase the coupling interval of the S3 and S2. Instead of 30 and 50, you can put 40 and 60. Put 50 watts here because I have less contact. So if you induce, you can increase the coupling interval and check it again. Obviously, this is not like the holy grail. So if you're still inducing, just stick to S2. But it's 85% in our cases. You can do it in with S3 without inducing a lot. In this case, we have induced self-terminated. One, the bundle branch reentry we have had to choke, probably with the movement of the grid more than the S3. And the second question is how to annotate. We use last deflection algorithm. So we always annotate at the latest component of the bipolar signal. So that can be done with inside with the last deflection. It's a bit more difficult with Carto, but you can do it with the LAM, but you have to do it more manually. So you have to open the window manually. One trick is that when you are mapping the scar, you have to increase the sensitivity to check for low voltage signals. When you are mapping out of the scar, okay, enough, then you have to decrease the sensitivity to avoid noise. But it's not difficult. Obviously, we have today Judith, that it's extremely one of the best FTs that I've known. It's not because I trained her. It's just by chance. No, I'm joking. but the FTs here in Prague in the lab that I've seen, they are extremely skilled. So everyone can do it. It's a very easy protocol.
I think the lab 4 is ready for you. So
okay,
we can switch to the lab 4.
So if you want to switch doing our ablation to another lab and we reconnect during the remapping, what do you think?
Yeah, we can do this. I would prefer this. We will be back at the end of the session. So then we will switch to the room number 1 in ICAM, then to Homolka Hospital for a case of left appendage occlusion, and finally we will go back to you.
Okay, great.
Okay.
So do you want to ablate yourself?
Yeah.
No? Probably what I would do is, you have the pedal here. I would increase to 15 or 16 ml, no, Judith, because it's not increasing a lot the power. Is that right?
I wouldn't ablate there, would you?
No. They should be sharp and they should be in the temperature rise.
Yeah, this is very dull, so I think this is not...
No, this is like far-fieldish. I'm not sure
that... Maybe you're not even touching myocardium, I think. Yeah, this is very near field there.
This is near field, yeah. This is contact. Tak, můžeme zkusit, počkejme, až budeme online. We wait till we go online.
You are online already.
Okay. So do you see the images?
Could you show them the electron atomic map, please?
So they still don't see it, just wait.
They're not seeing anything there.
We need you see the kind of Pruka. Okay, perfect. No, this is, the Afera is perfect. So maybe you can review, we can review the line that we did. So can you just show some RAO and rotate it upwards? Like, so make a line from the apex to the base of the ventricle, covering most of the juiciest electrograms that we saw.
It froze over there. It's not.
And then we try to obviously induce, not to overdo it. So we induce tachycardia, which is more apical, and we now in the process of annotating this, or just because it was again not tolerated, the patient is not very stable, but we try to do most of it in the sinus rhythm. And it's more in the apical part, so we did add some lesions in the apex, and now we want to induce during the real life, so we do three extras. So can we try to induce 270, the last one? Can we go Pruka online? Můžeme dát Pruka. Okay, so now we map a bit.
No, yeah, hold on.
Can you give me mapping?
Mapping, yeah.
So we have to be careful. This is worse. This is much worse. That's the apex was the best.
Show me.
So we have a hypotension. We don't have like another 10 seconds. Může nabíjet ten defibrilátor. So this one becomes interesting in the septum, but for later. Ne, počkej, ještě. No, už musíme. To jsme v papilárním svalu. Tady to je hezký, tady to je first systolic. Můžeme kardioverze. So we cardiovert and we have to wait. But this was the, můžeme ukázat tu signál před tou kardioverzí. This was the only presystolic potential that we got in the review screen. And it was somehow in the papillary muscle, in the kind of body of the papillary muscle. We are embedded into it. So the idea here probably would be to map more in the papillary. So do you see the review? There is some presystolic activity or just early systolic or just at the onset of the cures. So that would be a target for the next applications.
I'm between papillary muscle and septum. So that's an area where we have this. Now I'm a bit more inside.
So maybe we can, if it's possible, I know the body is there, but maybe it's shown on the map.
We can try to pace from
yeah, and
T,
pace map the morphology.
I'm skeptical that it will pace, but maybe.
It won't.
So that's a problem.
So can we pace from all the electrogram? And doesn't pace and
doesn't capture. All right.
No, it doesn't capture. So once you start to ablate, the electrograms are gone. So
there was maybe one pace.
Yeah, there was
a single.
There's more extrasystole.
I don't know.
Yeah, but there's very strange morphology for this lateral and this septal.
No, there's no convincing capture here. Guys.
Okay, because this was the site, so I believe we can do more applications here, and if the patient is stable. Yes. Do 4 applications here. And maybe add something on the other side of the papillary, like from the apex.
Was there captured during pulsing because we can't see the live PRAGUE screen?
You know the temperature.
There is, during the pulsing, there is the blood pressure shows that there is a continuous capture. So there is probably a lot of myocardium. Can we go to review screen to show the current capture? So there is a lot of myocardium which is underneath.
There is papillary muscle.
Můžeme klipovat ty sphery.
So it's capturing papillary muscle.
So as you can see now, it's most of the pulse is still capturing, so the lesion is not good. So in terms of there's still a lot of myocardium that we are able to pulse capture, I would say.
Now I'm more
apical. So yes, let's do it here.
Guys, we have one more question from the audience. Please listen.
Mapping because you have unstable VT.
What is the question?
Do you consider functional remapping of this?
Yeah, you can do functional mapping. Obviously, you cannot annotate because the system doesn't recognize that, but you can do 2 extras and just in this area of interest. And actually, there was so many interesting potentials that we would. It's a large car with multiple tachycardias, but I mean, we should aim for and it's still kind of monomorphic, slower VT. We should aim for it using pace mapping. That would be our strategy.
Yeah, the pace mapping with this.
At least it led us to this region, or mapping during the partial mapping during the ongoing VT.
So we are between papillary muscle, sliding between muscle and septum. Sklonit mapu dolů. You see, we are on ice. We are sliding on papillary muscle.
So
I will go maybe more basal to this area where we have this scar, and because that might be channel for, and there are some fragmented signals here.
Okay, tak můžete přepnout nahoru. Maybe we can switch to Homolka Hospital because they are waiting for.
All right. So, and should we consider like conclusion from your EP room, or would you like to
continue a little more? I think to modify completely the substrate and try to induce again.
All right. So, if there is a time, we will be back at the very end.
Okay.
Okay. Can you guys hear us? I don't know if they can hear us yet.
We can.
Oh, you can?
Okay, perfect.
Fantastic. Just, we're still working on the VT case, so we're going to show the other case that we needed to before going back to the VT case. This is a case with conformal. If we go to the next slide, please. So do you want to just present the history?
Let me quickly share the patient information. This is 72 years old woman, persistent AFib since last year. So we tried 3 times cultivation, 1 failed. And she also had a history of heart failure because of this AFib. And we added amiodarone. And we tried last cultivation last November. Then she got sinus. Next, please. And this is a sinus ECG the last time. Next, please. Okay, we performed TEE beforehand. After the last cultivation, she got normal ejection fraction and LA dilated and no significant mitral dilatation. Next, please. Or can we play the, yes. And we also checked appendage. This is TEE. And we also got CT scan. Next, please. Yes, this is a CT anatomic reconstruction. The ostium is 34 times 28, quite wide open appendage, but the shape is a bit like a chicken wing, as you see. Okay, this is a quick info for the patient.
So, and then this is you want to just talk about the study?
Oh, maybe you can go ahead.
Okay, all right.
Yeah, device feature.
So the patient is enrolled in this study. So the conformal device does not have regulatory approval here. So the patient is enrolled in this study called the GLOSS study, and it's looking at the implantation of this device using ICE guidance. So there's no general anesthesia. The patient's under deep sedation or conscious sedation, probably deep sedation, and we will use ICE to guide the implant. Let's just go to the next slide so we can describe the actual technology itself. This is the device itself, the conformal device, and it is a conformable device. You see that it has a nitinol framework and a PTFE covering over a foam-like framework, a foam-like construction. And the idea of the device is because of the foam, it seems to be able to engage to the tissue better to prevent peri-device leaks. Next slide. And here, okay, so let's just go through these various aspects of the device. Next. So let's click through these various things. Yeah, so the PTFE covering goes over, next please, keep going through all 5 of them. Yeah, that's the foam construction. Next, there's the nitinol back. Next. And it's actually held together by actually a string-like framework. So next slide. There's the device again. It actually only comes in 2 sizes, which is an advantage. About 80 to 90% of patients, we use 1 size, which is the main size, the regular size. And the remainder, we use the larger size. Next slide. Again, it shows the 2 different sizes. Notice in the middle panel, the tether is actually just a string. So once you extrude the device from the sheath, it sits in position, and it's connected with the very flexible thread-like connector. If you don't like the position, you can recapture it and reposition it, or do whatever you need to do. The other interesting aspect of the device, if you look in the top right image, after it's implanted, there's an injection. The injection, notice the contrast is pretty much held up. So unlike certain other devices where contrast can flow through acutely, here you have a pretty good understanding if you don't have occlusion by contrast injection, which tends to be pretty good in terms of the fidelity of the test. Next slide. We're also using a deflectable sheath. This is a multi-flexible deflectable sheath. It has the proximal deflection as well as distal four-quadrant deflection, as you see there. If you just click one more. So you can do things like what you're going to see. Let's just click forward there. If you click on the video, maybe it'll play, maybe it won't. Yeah, there it is. So notice there's a proximal deflection and a distal counter deflection. So it allows you, and this is not a conformal procedure, it's just showing the device in position, the flexible sheath. Oh, you want to show it? Okay. Okay, yeah, so, okay, it's sterile, right? Okay, good. It's non-sterile?
Yeah, we can just change gloves.
Oh, okay, I need new gloves. So the idea is, of course, you can deflect. This is a major deflection. Can they see this? I don't know if they can even see this. Anyway, so this is the major deflection, and then, for example, you can you can counter deflect in the same direction, in the opposite direction, anteriorly or posteriorly. So depending on the position, you can decide exactly where you want to put it. Let me have a gloves, please. So that's the description of the device itself. And now we're going to go ahead and do the implant. Any questions so far? You guys can hear us, right?
Yeah, we hear you.
Okay, good. Just want to make sure you're still awake. Okay, so what we've done so far, if we go to the fluoro, so what you've seen, we did a transeptal puncture with just a regular 8 French sheath. Then we put the sheath across and we exchange over to the multi-flex sheath, which you see here on fluoro. Let's go high quality, please, on the fluoro. Yeah, okay. So, no, don't want to do that. I want to do high quality.
It's high quality.
It is?
Yeah.
Okay, good. Now let's go back. Okay, so this is the multi-flex sheath. They're both going through the same transeptal hole. We maneuvered the CS catheter through the hole, just like Furman was talking about earlier. So if you look on the ICE image, so you can see the mitral valve, of course. You see the coronary artery. There's the appendage itself. If I counterclock posterior, you can actually see the left superior pulmonary vein. So it's actually a relatively small appendage. It opens up relatively quickly, but the real area that we're going to be occluding is right around that location right there. So let's go ahead and get going. Now, one of the things to remember, this sheath, by the way, the conformal device is delivered through a 15 French sheath. So we have to be very careful in these situations. Patients under conscious sedation, if there's only one thing you remember, when you're doing these procedures in a conscious sedation, be very careful. If the patient takes a deep breath in, you can suck in 20 cc's of air in a millisecond. Well, not a millisecond, but in a second or two. Okay, there it's coming out. So that's good. If blood is coming out, then in that case, saline was coming out, so that's good news. Okay, push this in. Just because I'm always paranoid, I tend to do some aspiration anyway. And we'll see. Maybe some small, there's 1 or 2 very small bubbles here. Let's get rid of those. Oh, you know what? We're just pulling vacuum here at this point. You know what? We're getting too much vacuum here. If I open this up, it'll come out this end, right? Yeah. Okay, it's okay. All right, so now what we're going to do is let's advance. So when I push this thing forward, the tip of this is relatively soft. I hope you can see there's like 3 or 4 little dots there. Those are fluoro markers at the distal end of the device. So I extrude it just beyond the device, beyond the sheath itself. So right now, it's a relatively soft pose. So let's undeflect the sheath a little bit. Actually, let's go to what view did we have? 40 something? Let's see, 20 degrees or something. I'm going to go a little bit REO, a little bit caudal. Okay, so I'm using the major deflection just to get close. No, let's leave it here. Yeah, let's leave it here. So there, I'll just put fluoro, though I'm really only paying attention to the ice. So advance here. Now what I can do is use a distal quadrant deflection, deflect it down a little bit, maybe a little bit anterior. Yeah, I like this. down, advance deeper. So I like this position. And again, because the foam is how you're leading here, it is relatively soft. So I can push in a little bit. And now what I'm going to do is unsheath the device. So I'm slowly withdrawing, take a little bit of deflection off, withdraw a little more. And once that's there, then I flip this forward and push it forward. So now it's connected just with the flexible tether itself. Let's see, how's it looking? And you can actually see, okay, there's the device itself. You actually see the tether itself right there. So let's do I'm going to get a little bit closer with this, and I'm going to do a contrast injection here. This is contrast here? Okay. And let me just aspirate. I want to make sure there's no bubbles in here. Okay, there we go. Good. Okay. Are we at 15 frames per second?
Yes.
Okay. That's very nice. You actually see, I mean, this is one thing I really like about this. With contrast, you can tell very nicely that there's nothing going beyond this. Now, the next question is it stable? Because that's sort of important. So we'll pull back a little bit, pull back the sheath a little bit. And now let's do a tug test here. This understanding also. Oh, yeah, that's a very aggressive tug test. Yeah, it's not going anywhere. Okay, that's good. So we're actually pretty happy with the position. Yeah, I'm very happy with the position. Anybody objecting? No. Everybody else seems happy, which is rare. They usually don't like where I put it. But anyway, and then what we do is, so basically there's a suture that goes, just like with the micro, the suture goes all the way down and comes back. So I cut the suture, one of the two. Let's get this close. And then that acts as a backstop. And pull it out. And that's done. We're going to do a final injection, right? Let's do a final injection. Okay, let's put this, yeah, thank you. I'll get the, okay. Let me just aspirate one more time. Okay, good. You know what? I think this needs to be tightened here. Now the patient's starting to snore. This is when you get really nervous. Okay. This is actually good. Notice that the contrast is being held up too. There was a little bit that went past it when we squirted aggressively, but then it gets held up. So this is actually really good news. I like this position. So we're pretty happy with this. We'll take this back. We can look at, it's interesting with this particular device, the ice is useful for initial positioning, but assessing leaks and stuff, you really can't see anything acutely because there's always microbubbles that are caught up in the foam, so you get a lot of shadowing. Once the patient comes back for like a 3-month or whatever TEE, then those are all gone and it looks like any other device. But anyway, we like this position. Anything else you guys need? Okay, good. And then, of course, we just got to verify there's no pericardial effusion, which looks good, and we're done. Any questions at all, or otherwise we're going to go back to the VT case?
Vivek, very nice. I didn't see you do a lot of measuring. Maybe I missed it, but could you comment on the range of sizes, appendages that you can cover with these devices? And would you say that you can choose a device using X-ray and general impression alone, or do you still need to do these standardized measurements?
Yeah, good question. So one of the nice things about the device is there are only two choices in terms of device size. And the regular size, which is what we use, covers about somewhere between 80 to 90% of device sizes. So it's only when it gets really big that we have to use a larger size. So most of the time, there's not much of a decision process, luckily. I like that, actually. And so it becomes pretty straightforward.
And is there a size that's too small or too big in terms of diameter of appendage? Something that...
Yeah, it's a good question. Well, so the regular, by the way, accommodates up to 25 millimeters. So 25 millimeters, by the way, is 25 millimeters on average, because unlike other devices, if you squeeze in one direction, it tends to extend out in the other direction. okay? So you want to look at 25 millimeters, take the major and minor dimension and average those two. In terms of, actually, what is the largest size? I think it's 40 millimeters is the largest. Yeah, so, 32, that's right. So the large device is 40, but in terms of mean dimension, it should be 32. So again, that means if you have a 40 in one direction, but let's say a 22 in the other direction, it would still accommodate it. And in terms of measurements afterwards, you're right. There's not too many measurements we take. What we're really looking for is stability, so position, and not too proximal or too distal, stability, hence the tug test, and of course occlusion, which is why I do the contrast injections. Yeah.
All right, probably there is one more case.
Yes. So I'm gonna go back to the VT case. Or is there a question?
Just last.
Sorry, one more question.
Do you hear me?
Yes.
Can you explain again how would you introduce the ice into the left atrium?
Sure. You know what? Let's just do it live. It's the easiest way to introduce it. So normally you have a guide wire here, right? So unfortunately, I've already pulled everything out. Okay, but let's say, where's the hole, by the way? It's right about here. Can we just put some color just so I know where the hole is? You guys, can you put some color on this thing? Yeah. Yeah, open it up. Okay, good. Let's just find this hole. Where is it? Okay, there.
Right there.
So right about, where is it? Right about there. You see that right there? You see the hole right there?
Yeah, we can see.
Okay, stop there. You can get rid of the color. So now normally you have a guide wire across here, right? And so what you do is, the way I like to do it is mainly based on ice. So I deflect toward this, move toward this, and then go across. This was too easy. Sometimes it's harder to do, and the keys, I would say, if you're using this kind of a catheter, this is the Acuson one, what you can do is you lock it, and yeah, what I typically do is tilt toward the left a little bit. That actually gets you a little bit closer, and then tilt forward until you get next to the hole, and then you go across. That's usually the approach that works the best. You can also use fluoro, so you can look at the ice, look at where the guide wire goes across the transeptal hole. You know the vertical level. Go to a little bit of LAO and maneuver to that location and go across. So that's the other approach to use.
You will never see
the other approach, by the way, is you can do 2 punctures. That's always an option.
You will not see the tenting on the ice, right?
Well, no, because you're pointing right at it. So your imaging plane, you can see where you're on until you get close. And once you get close, then you're sort of deflecting, pulling back a little bit, and then advancing to go through the hole.
Thank you.
All right, now we have to switch back to ECAM because they want to conclude both VT cases.
Okay, sounds good. We'll see you back in a bit.
Thank you.
Thank you.
So, welcome back.
So welcome back for Afera VT case, post-MI, inferior scar. And just to show you, so we were dealing with this apical VT, so we ablate much more, and then we induced this. What you see now, it's much more basal. It's positive V1 to V6, and it's more lateral, so it's going up lateral, basal. So generally, if you look at the voltage map, there's still area which we didn't treat it, and has a very nice potentials. And we also have a very nice pace map. So she can show you the pace map, but maybe the way that it somehow resembles. So it's 90 using the software, but if you look at the morphology, it's a more or less the one. And also, I believe what's important, if you can show the ice, then it's important to get in good contact with the tissue. So we generally want to really extend the lesion towards the mitral valve to be like in this embedded point underneath the mitral valve, which hopefully you can see now. And it's very nice contact there. The electrograms looked very nice, so our idea will be to add few applications here to transect this VT and see what's going to be. So generally we keep still doing this. So let's pause.
So quite complex lesion, as you can see. That would take, with conventional ablation, a long time. But here it really makes life much easier. And yeah, as usual, there are different exits, different arrhythmias inducible. It's very complex substrate.
A large scar.
Large scar.
Open up slightly.
So we are moving towards this previous scar, but we have to wait a little because of blood pressure. On ice, you can see also there is a scar, although there is not very thin here. So it's not a real transmural, but there is.
This is nice. These potentials are very nice. So can you show that on the?
Can we paste from T?
Can we show the real-time images? Real-time PRAGUE. Real-time PRAGUE.
Lovely! Wow.
That's amazing.
It's amazingly
so
long.
See the late potentials. Hopefully you can appreciate. So the signal quality of the system is very nice. This is, by the way, bi-V pacing. So we are pacing close, so they are not that late. If we would pace from the RV, can we pace from the RV just to get these late potentials really late, slowly? So you can you record and show under the PRAGUE and go 200?
It's amazing quality of potentials. These close unipolars.
Okay.
Close unipolars in that region, very nice. And we are lucky that we can pace even from this small potential, and we get practically identical match.
Okay, so let's ablate here.
Continue here. And you see nice contact on ice again in the scar area. Despite the fact that it's relatively smooth, it's not sliding. It's like attached to the tissue, so it's a difference from conventional ablation. You see signals are gone. Yeah, so...
Yeah.
We have always a little bit of pressure drop after applications. And there is no capture now, practically, on the tissue in this area where we ablated already. So we do some more lesions here. There is late potential again, if you can see this life map or life signals. When we paste from right ventricle, that will be even more pronounced.
No, stop.
Well, not really.
Now the agents disappeared.
There is no signal anymore after delivery.
Už bych toho nechal potom.
Ještě dojedu to dolů. Any questions?
There are none so far. And we had to go also to the other room in ICAM. We have been there only once. So if you feel that we should switch.
You can go there. I mean, we will try again to induce. Hopefully this one will not be inducible, and we feel that we might be close to the end of this case.
Not to overdo it.
And if there is a recurrence, we have to go epicardial next time probably, because there might be some epicardial component based on pattern of ECG. There might be some epicardial exit, but for today, I think it would be enough.
Yeah, we've given about 80 lesions now, right? So.
You see again maybe these late potentials during. And this is biventricular pacing because we did not want to expose patient to hemodynamic stress. Can we see moving signals instead of map? Can you live PRAGUE? You can appreciate this very delayed potentials, fragmented. That's a margin of this scar. And you may see on ice again that we are in the scar region. Asi už jo. So basically that's the plan, to finish this line and then try to induce again. And we probably will end up then. So if you want to see case next door, you can go there.
All right, we will switch. Thank you.
Okay, they've gone to Cath Lab 3. Okay, that's good. And this has been a slog.
Okay. So Judith, we're going to be on air. So hello everyone.
Hello, you're live again.
Okay, great. So we are ablating the second area. So please, in the meantime, we have done the turbo map of the S1. So Judith, can you show us the turbo of S1, please? Okay. But in the travel CT, switch off the CT. Okay.
Okay, I will stop for a while.
Okay. Show us the, okay. So we have done the turbo map of S1 to prove what is different between S1 and S3. So this is, so can you, Judith, show both maps? Okay, so in the left, you will have S1, is that right, Judith? And in the right, where the CT scan is, we have the S3, and you will see the difference, okay? Okay. Okay, with the S3, you have clearly two areas. And with okay, that area that Judith will show us, where we have ablated that more mid-ventricular, okay, this area, perfect. And the other area, exactly, this septal area with a lot of colors. And if you see the S1, synchronize, please, Judith, both. Okay, okay. You see that in the area that in the S3 there is a lot of colors. Actually, the latest activation in S3, it's nothing in S1. You see this is S1, and show us in the S3. Show us the signals there in S3, Judith, to show us that there is the most interesting signals of the map for us. Yeah, exactly. Annotation. Exactly. Look, these very fragmented signals in the S3, and it's an area that you would have completely missed in S1. Can you propagate both maps, Judith? So we have ablated the most lateral area seen in S3 and not in S1. We have looked for loss of capture with long-to-stem QRX during ablation also. With inside, you can pace and ablate at the same time. You see the propagation of S3, and show us the propagation of S1. In S1, there is some delay up there, but not as clear as in S3. So, okay, Judith. So, can you show them the ablation that we have already done with only S3 and CT now? So the strategy will be to ablate the posterior septal region of the second area where we are now, and then check for lack of pacing at that area. And if we check for lack of pacing with long-to-stem to QRS in both areas, then we'll put the grid again and do an S3 map again of that area. If there is something residual, we will re-ablate and we will remap. And only when the remap is clean, then we will induce. So probably it will take us 20 minutes more to complete the full ablation and remapping procedure. So this is the ablation side that we have done. Okay, with sometimes we have to increase to 40 and even 50 watts, because despite the decrease of the impedance of 10 and 15% ohms, the signals were still there with long-to-stem to QRS signals. Can you show them stem to QRS during ablation, please, in the PRAGUE, the longest one? Okay, you have seen now in the PRAGUE that despite ablation, we still had long-to-stem to QRS in that position, so that's why we have increased the ablation. Probably there is some kind of epicardial component, but let's see if we can get rid of it. Now it seems at the end that we have no more long-to-stem to QRS, and now we're going to ablate from the post-occipital. Can you go to the post-occipital and go for ablation, Judith? Okay, so can you zoom in because I'm a bit old? Thank you. Okay, so we will ablate. I have 12 grams, so 40 watts. Let's see. Okay, the impedance dropped 10%. I will go to 30 seconds. Can you pace during ablation here, please? Okay, it's not capturing here anymore. What's the output here during pacing? 10. Can you increase to 15 just to check? Okay, so this is dead. This is dead tissue, okay? So we'll go more down, okay? Okay, it's a not very stable area because of the papillary muscle. Is that true? Is that the papillary muscle? Can you show us the papillary muscle in the electron-anatomical mapping system, Judith, please? So in red, you have the papillary muscles of the CT. So we are very close to that area. So if you have no eyes, that's another tool that you can have, okay? Okay, great. Go to the S3 again. Okay. Okay. Can you paste from here? It seems there is, all of this area was easy to ablate. Eh? Yeah, it's thinner. This is like it's 5 millimeters. Eh? It's not so thin, but probably it's less fibrotic tissue as you suggested. Yeah. Because in the other area we're very more in the deep part of the scar with more fibrotic tissue that for radio frequency it's not the best scenario. Can you pace again? Okay, there is nothing now. So let's see if we can remap and see what is gone. Probably there is still some signal, so we're going to do a remapping with the S3. Okay, okay, so can we change?
What's the total ablation time so far? Can you...
Okay. Can we flash the grid X, please? 103,000. Oh, I'm a bit tired to convert to minutes.
100 and 1,000.
So 20 something, no? So it's not a lot. So probably will be not enough. Can we flash the grid, please?
Můžeme propláchnout HD grid.
Okay. So we'll do now the S3 again, okay? Let's see, and now probably, Judith, it's better to have like only the inside, the old S3, the basal S3, and after that, the new S3 altogether, inside and inside probably now. And as you have seen, we use the CT, but the main use of CT is to look the wall thickness, to see where are the channels, and then to check if these channels have slow conduction properties or not. One bad thing of this patient could be that if we are so close to the mitral, it could be that we need to close the line until the mitral. Let's see. Okay. Okay, we are. Okay. I think we still have areas. Yeah, so, okay, S3, please.
Excuse me. I have one question.
But we are
question? Yes. Can you please explain the map settings are part of late potentials for AutoMap for S3 protocol?
Delayed.
Yeah, so we use last deflection to annotate late potentials. We have very low sensitivity when we are in the middle of the scar to look for late potentials. We decrease the sensitivity outside the scar to avoid noise. We have autocolor, so to have always the latest as purple. And we distribute the isochrones to 8 isochrones. Judith, can you show us how you show them how you configure the map? Okay. Yeah, can you see the inside screen now? Okay, you have last deflection here, sensitivity, low sensitivity in the scar, 0.07, and you can even decrease, okay. We have a score of 70. It means that you will only collect points with morphology similar to pacing, okay. cycle length tolerance of plus minus 5 milliseconds to avoid collecting S2 and S1. And what else? And show us the isochronal. The autocolor, okay.
There's something.
And color contour 1, okay. Non-sustained because of, okay, so.
Okay, I was moving the
so at least we have not a big signals now yet. Let's see, okay. Okay, it seems pretty clean.
Okay.
It seems pretty clean. Either we have poor contact or it's clean, let's see.
Let's map it here.
Okay,
the septal
paste
part.
please. This is the other region.
There's something here.
It's very small. Let's. Yeah, there is something. There is something residual
so we
here.
need to ablate more here.
Yeah, put a cyan, please, in white, please. Okay. So this is an area of isochronal crowding that we didn't ablate, actually. Yeah? So it's obvious that we have here. Okay. So go up and the other region to make sure that the other are. Okay. Again, the same. Okay, so we have to ablate more this area.
Yeah, go here. This looks good during the S1.
Okay, this looks good.
This is
perfect.
Okay,
so go back to the other region again. This is
okay,
critical. Again,
yeah,
the same.
Yeah.
Okay. So I could go back again to the main part,
and
to the lateral wall and to the lateral wall. No? Here it's clear that we have to ablate more. Okay. Okay.
What about this part here, closer to the his?
No, this is okay.
Okay.
So I could go to the first
Guys,
region.
we are approaching to the end of the session.
Okay.
And I think that your case was pretty straightforward in terms of mapping and also ablation. So we can't wait until you homogenize the second region, and we have to switch for the last couple of minutes to Homolka Hospital. So
Okay, so thank you very much. If you have any question after that, you can ask us, okay?
there are no more questions. So thank you very much.
Perfect.
And goodbye.
Okay. Thank you.
Bye-bye.
Should we try and...
Let's go.
Now we're having some automaticity, I think, from the PF lesions. I think it should quiet down. It's already starting to quiet down.
Okay.
Let's do me a favor. Pace the atrium a little bit faster for just a few beats.
So Vivek, you are back
I think it just
live.
needs to quiet down. It just takes some time.
Can you hear us?
Coming back to our slide.
Actually, try to induce, please.
Okay.
Vivek, can you hear us?
So we can.
Oh yeah, yeah. Hi guys, how are you?
Yes, hello. So you're back live. We have about 5 minutes left in the session. I guess everybody's curious about how the EPI approach finally went and what you did meanwhile.
Yeah. Oh boy, I don't know. How, okay, let's just get to the. So I'll just tell you what we did. We took a. We went just in terms of the pericardium. We took an agilis, went into the pericardium, a long curl agilis. We put a multi-purpose catheter through the agilis. Through that, we put a a microcatheter through which we put a CTO wire. We punctured out one of the distal vessels, injected contrast, and it looks all adhesion. There are a bunch of adhesions. We're able to advance the wire, but it moves to certain locations, but then you clearly see adhesions in other locations. And then we said, okay, there's adhesions, and we pulled it out of the pericardium. Then we went transeptal. And now let's start showing the map. Can you show? Let's go to the voltage map first, and then show the VT.
Sure. Can we show Flora on the microcatheter?
We only have 5 minutes. Let's just
5 minutes.
Not it.
We have 5 minutes only.
Yeah, I think we took a lot of time for the other stuff.
All right.
Okay, let's zoom out. And actually, we got to show the VT, please. Can you guys show the VT? Okay. Yeah, you can show them, Prika. Can they see it? Yeah, so there's the VT. You can drop to 50 speed or something. It's a sort of an unusual VT, but there you see it. Okay. And if you now let's go to the cardo map for a second. I'm sorry. It's Afera, by the way, not cardo. It's going to take me some time to get used to it. Anyway, so this is the Afera map. So this is an endocardio map. If we rotate around, please. So we map transeptal, obviously. You can see the mitral valve, etc. There's some patchy low voltage stuff, especially when you get toward the this perivalvular septal substrate. And I thought this was going to end up being a VT that was going to be perivalvular. It may still be to some extent, but then we induced the VT and we mapped it, and we were able to have it slow enough and push the pressure up. So here's what we saw. It was very interesting. It was a focal it looks like a focal spread from this location, as you guys see, okay? Can you actually show them any of the points, so they can see? Yeah, no, not the ablation points, just the timing. Yeah, the timing of any of those points, if they can see.
Yes.
Yeah, just to show. It's not that early from the cure. And we certainly didn't see any interesting diastolic potentials, that's for sure. So you can drop the sweep speed so maybe they can see that better.
Mm-hmm.
And drop a line from the beginning of the QRS if you don't mind. It's hard to see. Maybe drop the sweep speed further so they can see it. 50 speed. No, 50. Yeah, just so they can see the beginning of the QRS to the extent that it's hard. It's like difficult to see. Okay, now go back and make it a longer sweep speed. Yeah. So you can see this is as early as we got. I mean, you get the hint that there's something deeper in. Obviously, we're not pericardial in this case, so we actually couldn't map the epicardium. This is the best location. Our initial position was not that great. You can actually see on ice where we are now. The one nice thing about Afera is you can actually see the ball pretty well. So that's nice. So on fluoro, let me just fluoro really quickly. So they can see the catheter position on fluoro. Oh, no, it's moved, but anyway, in this location. And then with the catheter in this location, we went ahead and delivered energy. And we delivered RF. And I have to say, we didn't get very good heating. I don't think our contact was that great from the initial position. We delivered energy, and with the second application, I believe it was the second application, it terminated. It was a late termination. There's no two ways about it. It did not terminate early. Then we were able to reposition, and we delivered both RF and PF lesions in this location. And we've been doing testing, and so far we have not been able to induce anything. After the ablation, by the way, we did see what looks like some automatic activity from that location, which we oftentimes see when we deliver PF energy. I think you guys may have talked about that in the other case. I don't know. So it's I think we'll have to wait and see whether or not this is effective. Obviously, time is going to tell. I wish that we're able to have mapped pericardia, because I think that may have been a very useful approach here. I don't know. Yeah, so that's where we're at. Well, any questions at all? Or is the time up? Interesting. Wait, can you guys hear us?
We cannot hear them.
Yes.
Oh,
no,
yeah.
it's quite convincing, actually.
Dumbfounded or bored. It's one of the two. Dumbfounded or bored.
We think that it's like really exiting from epicardial because of a late termination. Actually, during the first application, we saw just slowing down the cyclant.
Yeah, it slowed down and then eventually terminated. One other important point, we did do an entrainment from that location, okay? And the PPI was very long. I mean, there was clear fusion. It was, it was close, but there was definitely fusion, which is not a surprise. But also the PPI was not short. I mean, we're probably like, 40, 50, 70, 80 milliseconds?
80.
Oh, yeah, let's look at the review. You can actually see on, can you show them the review screen? I mean, it was not a good, what was the actual PPI here? Can they see it? Okay, so the tachycycline was about 370 or something. And what's the PPI there? I mean, 470. Yeah, I mean, this is like, no, even if we're generous and bring it back a little bit, we're still going to end up being about 80 milliseconds out. So really, it's not a great position. But I think it's the best position that we had.
I guess it's also not a great pace match either, right? So
no, the entrainment. Show the 12 lead, please. You can see there's clear fusion too.
Yeah.
Drop the sweep speed. It makes it easier to see. The pacing, the entrainment is on the left, and the right is obviously the VT.
Is anything else inducible? No.
No. I mean, now obviously the question is going to be what happens, with time. We've not induced anything else. We'll do a little more, but I think that We did, as I said, we did multiple applications. We did 4 PF applications with good positioning. We did 2 successive RF applications. The problem is, as with time, you get edema fairly quickly. So then you're starting fighting the distance issue. So, anyway. Okay.
All right, I can't see any more questions. So if we can conclude the session, if you agree, if you have no more comments or...
Yeah, no, I think so. I mean, I think that, I guess the only other comments I'd make are, number one, I think, I almost wish we were doing it live. Unfortunately, we weren't, but the mapping was very quick, which is, when you're in tachycardia, a fair mapping, I'm very impressed with how quick it is. Number two, I don't have a good feel yet of how durable these RF and PF lesions are with the FARA. So I do think that we have to wait and see. And yeah, I think that's all I have. Anything else, Peter?
Actually, can I stress, I'm asking you, what is strategy, if you look at the strategy, how to apply like RF, like we did, like RF, okay? And on top of RF, you put like several like PF. So it's our strategy to doing this Honza and Toshi. So here we're really doing like RF and add some more.
Right. Yeah. So I think, look, this is all based on one publication that used a different catheter, not this one. Okay. So I think we do also, right? We do both RF and PF and cross our fingers. But in reality, I don't know that it makes a difference. I'm not sure that we may even be hurting ourselves by switching between. It may be better to stick with PF and do multiple applications.
But actually,
I don't know.
when we have here like a lot of like scarring, actually my preference is going really like PF because we know that we are going through the scar. With RF, even like crazy burning, you cannot.
Yeah, PF definitely works
like,
better through scar. I agree. But I guess my point is this: we need some good preclinical data with this catheter, looking to see whether or not combinations make a difference, and if they do, which should you do first? So anyway, I'll leave it at that.
All right. So thank you very much. I think very interesting learnings from clearly how you manage a challenging case. I don't think we have any more questions in the audience, and it's time for our break here. So thank you very much for that case.
Thank you.
Bye,
guys. Thank you. Oh my God.
Well, it ended up good, but the last minute.
For the last session of lectures on VT.